It is now my pleasure to turn the webcast over to Heather Wakelee, MD, Associate Professor of Medicine and Oncology at Stanford University. Dr. Wakelee, the floor is yours.
Thank you. So welcome. I'm going to be going over principles and application of immunotherapy for cancer with a focus on advanced non-small cell lung cancer. And as you can see, these are our core faculty who helped to develop the slides, Dr. Naya Rizvi and Marianne Davies. All right, so moving on to the agenda here, what we're going to be covering today is looking at lung cancer and the immune system. So we're going to be defining the role of the immune system in cancer, talking about tumor escape from immune surveillance, harnessing the immune system as a treatment strategy for lung cancer, incorporating immunotherapeutic agents in lung cancer, looking at efficacy and safety of agents in development, managing potential adverse events associated with immunotherapy, as in our last case that we just discussed, educating patients about immunotherapy, and selecting patients with lung cancer who may benefit from immunotherapy. So first we're going to do a little refresher on the immune system. So in this cartoon you see in gray a tumor, which is going to be presenting lots of tumor antigens. And responding to it in yellow is a T cell with the T cell receptor interacting with the class 1 MHC presentation of the antigen. So that's sort of the basic first step of immunology. However, that interaction is obviously going to have a lot of other effectors that play a role, which we'll be getting to on the next slide. What we also have as sort of one of the key is that in order for the immune system to really understand what antigens are being presented, it's best if those antigens have been processed by a dendritic cell or another antigen-presenting cell. So if you have an antigen-presenting cell, then that's going to do a better job of interacting with the immune cells, the T cells, to create a better immune response. Now, as I mentioned, there are a lot of other players here. It's not just the MHC and the T cell receptor interface. There are a lot of other signaling pathways that are very, very important. So if we look at the green side, the activating signals, there are a lot here. We're not going to be talking about those as much today, but you will be hearing more about them in years to come as there's a lot of work being done on trying to get these signals to be upregulated to increase responses to tumor. So we've got CD28, OX40, CD137, CD27, a few others. And then with inhibitory signals, some of these are going to be more familiar to you because we now have agents that are actually working against these, trying to inhibit the inhibitors and therefore rev up the immune response. So CTLA-4 was the first that we heard about with the ipilimumab, and now we have drugs that hit PD-1 as well as PD-L1 with nivolumab and pembrolizumab, the two that we'll be talking a bit more today because they've been approved to treat lung cancer and are both PD-1 inhibitors. And then some of the other players, TAM3, BTLA, VISTA, and LAG3, we'll be hearing more about in years to come as well. So this is going to be a little bit of a cartoon here. So tumor immunology overview, starting with the gray tumor releasing antigens. They go to the dendritic cell as the antigen presenting cell. They are then processed, and MHC and B7 there as part of the signaling. That will then go into a lymph node where it will find a T cell. And that T cell is going to interact with the tumor antigen being presented to the T cell receptor, and then interact with the CD28. B7, which is going to be one of the signaling pathways important to get this immune system to work. Then you have an activated T cell, which then goes back out into the periphery and hopefully reaches the tumor, recognizing that tumor antigen on the tumor, and then leading to basically killing the tumor through T cell activation. So you've got a clonal expansion at that time, cytokines are released, you've got perforin, and hopefully you're going to end up killing the tumor. So that's how we're getting the immune cells to work against the tumor. And again, this is review for most of you, but always good to go through it. So basically what's happening over time, though, is that when you've got this T cell response against the tumor, eventually some of those tumor cells escape and then those start to grow. And you've got basically a lot of immune deregulation where the tumor is working to suppress the immune response against it. And one of the main ways it does that is through the PD-L1, PD-1 interaction. So how do we how do tumors work to dampen the immune system? Well, as I mentioned, one of the ways it can do that is by expressing proteins that basically tell the immune cells to back off or to not become as active. And so one of those key ones is the PD-L1. And you can see actually on the right here, you've got a gray tumor, and it's got purple PD-L1 protein on the surface. And that PD-L1 on the surface, if a T cell comes in, T cell is going to have a PD-1 receptor. So that PD-1 receptor interacts with the PD-L1. That's basically going to turn off the T cell, leading to anergy. And so that's one way that the tumors can evade immune response. There are many other pathways, but again, today we're going to be focusing mostly on that particular pathway because that's where we've been able to figure out how to block that inhibitory system and sort of cut it off so that you don't get that way of turning off the immune response against the tumor. You can see here on the left, we've got other negative immune regulators, the inhibitory receptors we just talked about, they're suppressive cells, and then there also suppresses enzymes such as IDO, and there are drugs now being developed to target IDO. And there's some circles there to highlight those two things we were just talking about. Now, PD-1 is a target in cancer therapy. Again, this is showing the T cell in yellow with the tumor cell in gray and showing this interaction between CD28 with the CD80 and other mechanisms. And then you've got it here highlighted where you've got that negative receptor pathway going on, and that's going to turn, here's the T cell kind of coming in with the PD-1, PD-L1 blockade then happening. That's going to cause a negative regulation and turn off this primed interaction between the CD28, CD80, CD86, which was leading to some activity against the tumor. And here in red now, we're showing these antibodies that are being developed to block PD-1 or PD-L1. So on the PD-1 side, you've got nivolumab and pembrolizumab, which are two drugs available currently, and then others in development, including pembrolizumab. And then blocking the PD-L1 side of the equation are the MPDL3288, also known as atezolizumab, the MEDI4736, also known as durvalumab, as well as other compounds in development as well. Now this sort of the simplified version. One thing that's important to note is that PD-L1 expression is not limited to tumors. PD-L1 expression can also be found on the tumor cell, on the tumor infiltrating cells. And so when we think back to our first question, you can see PD-L1 expression on both tumor as well as on the T cells and on other aspects of the immune system as well. So things are a bit more complicated than we have even on this schema. All right, so how do we bring these immunotherapeutic agents into the treatment of lung cancer? So this is a rather busy table looking at some of the nivolumab efficacy. So this is the earliest trials with nivolumab, using it as a monotherapy in patients with lung cancer. And you can see that as a monotherapy, the response rates are around 20%. The 1 milligram per kilogram dose wasn't quite working, but the 3 and 10 are both showing good responses in that 20% range, without any real difference between the 3 versus the 10. And therefore, the 3 milligram per kilogram dose has been the one that's really moved forward. So those impressive results, again shown here with some swimmer's plots, as well as a overall survival curve, led to the randomized trials, which we'll also be talking about today. So in this study, which was a small number of patients, 130 patients, the 3-year survival was 18%, which is pretty good for an advanced stage non-small cell lung cancer population. And we look at the duration of responses in some of these patients, again, it's quite long. Some of these folks are out here over 3 years and still on treatment. So the Checkmate 063 trial was a phase 2 study. It was for patients who had previously been treated with at least 2 lines of therapy, and they got the nivolumab at 3 milligrams per kilogram every 2 weeks, continued until progression. And again, this also showed encouraging responses. This is a waterfall plot showing response here. This is looking at patients who are still alive and still on treatment, and you can see that there's a good number here, a lot of very impressive responses. Here the response rate was 17%, with again some ongoing responders, and a median overall survival of about 8 months, 1 year over survival of 41%. But again, this is still some of the early data. because we've actually had now some randomized phase 3 trials. This is the Checkmate 017, which was nivolumab versus docetaxel in previously treated squamous cell non-small cell lung cancer. So this is an open-label randomized phase 3 trial looking at patients with metastatic squamous cell cancer who had previously had a platinum-based chemotherapy regimen. 272 patients randomized 1-to-1 to get the nivolumab at 3 milligrams per kilogram every 2 weeks, or docetaxel at a standard 75 milligrams per meter squared every 3-week regimen. And this was designed to look at overall survival as the primary endpoint. This was published in the New England Journal at the end of May, and that was the exact same day it was presented as an oral at ASCO. And the reason it was presented as an oral at ASCO and made it into the New England Journal is because of this survival curve. You can see here that the survival was significantly better with nivolumab, hazard ratio of 0.59, highly statistically significant, a median of over 3-month improvement, 9 months with the nivolumab versus 6 months with the docetaxel. So the FDA approved nivolumab based on these results, and that approval was actually back in the springtime. What about for the non-squamous patients? If you recall the cases that we talked about, I mentioned that in non-squamous this is also approved, and that was based on this trial, the Checkmate 057. Similar design, looking at nivolumab at the 3 milligram per kilogram every 2 weeks versus docetaxel at 75 milligrams per meter squared every 3 weeks. The difference here was that these were patients who had failed 1 prior platinum doublet, and if they had a targetable mutation, they'd had to have an appropriate TKI therapy first. And when we look here at the results, you can see that, again, there was a statistically significant improvement in overall survival, hazard ratio of 0.73, and again, about a 3-month difference. The numbers are shifted up a little because the non-squamous patients overall tend to do better. But again, very impressive results here. Now, what's different between the squamous versus the non-squamous is that with the squamous patients, this PD-L1 expression didn't matter. So PD-L1, remember, is what we usually think about as showing up on the tumor as the way to evade the immune system. So it would make sense that if tumors have high levels of PD-L1, those tumors would be the most sensitive to blocking that PD-L1 signaling. However, in squamous, that didn't pan out. The patients who did or did not have the PD-L1 expression on their tumors had the same potential benefit of that response rate in the 20% range and that improvement in survival. But for the non-squamous patients, the PD-L1 expression did seem to matter. So if you look down at the patients with that at least 10% level versus less than 10%, those with a greater than 10% level had a median overall survival of approaching 20 months with the nivolumab versus only 8 months with docetaxel. Versus those with lower expression, there really didn't seem to be a big difference between those getting the nivolumab versus docetaxel, a benefit to both. And so at least in the setting of the non-squamous, there's a hint that this PD-L1 expression seems to matter. But PD-L1 expression is a very confusing concept. The concept's simple, but the reality of it is complex because every company that's developing a PD-1 or PD-L1 drug has its own assay for looking at PD-L1 expression. And the cut points as to what's positive or not varies for each company. And it also depends which company as to where you look for PD-L1. So some assays only look on the tumor and some look at the tumor as well as on the tumor infiltrating lymphocytes. And so there's just a lot of confusion still. Okay, so but based on this trial, the FDA expanded the approval to nivolumab to include patients with non-squamous histology, and that approval just came this month in October. It is important to note that there is a PD-L1 assay available, but it is not a companion diagnostic, meaning you don't have to do it. It's a complementary diagnostic, meaning you can check it for your patients before prescribing the drug if you want to have a better chance of estimating who's likely to benefit or not, at least for the non-squamous patients. Okay, so moving on. We've talked about nivolumab. Let's talk about pembrolizumab and the data here. So this is the Keynote 001 study. This was the phase 1 sub-analysis, and this was sort of a big trial looking at a lot of different types of malignancies, mostly, though, advanced non-small cell. There were 500 patients with that setting. And this was looking at multiple different doses, so 2 milligrams, 10 milligrams, or every 3 weeks, or 10 milligrams every 2 weeks. Again, looking for responses. And this was published in the New England Journal in April of 2015. So when we look at the total patient population of nearly 500 patients, the response rate was again around that 20% mark. It was a little bit higher for those who had never been treated versus those who were previously treated, and a little bit higher in the squamous versus the non-squamous, but all really close to that 20% range. And when we look at the progression-free versus the overall survival rates, a little bit better for overall survival for the treatment naive, but not that big of a difference. And this is looking at the PD-L1 assay that they've developed. And you can see that their cut point, instead of being that 10% we talked about with nivolumab, it's closer to 50%. So strong is 50 to 100%. Weak is under 50%. With nivolumab, with their assay, it's 10% cutoff. So there's a lot of variations in how do we look at PD-L1 expression. So when we look at the KEYNOTE-001 study for pembrolizumab efficacy, you can see that for patients that had the higher expression, at greater than 50%, the response rate was much higher. It was 45%. Now, this is a minority of patients, it's only 73 out of the patients looked at. For those with moderate expression, the response rate is about 16%. And when we look at the no expression, or less than 1%, there's still a response rate, but it's much lower. And it's that the fact that there is still some some response even without an expression that again leads to confusion about what does it mean to be PD-L1 positive or negative. So here you can see the PFS, much better in those with the higher levels of expression, and kind of whether there was no expression or up to 50%, it was pretty much the same. And the same with overall survival, better for those with the higher levels of expression. And this proportion score was looked at in 356 patients. Okay, now pembrolizumab was also just approved in October for non-small cell lung cancer patients, regardless of histology, but with a companion diagnostic looking at PD-L1 and looking for this proportion score of at least 50% based on this analysis from the KEYNOTE-001. Okay, so we've talked about sort of the data that's led to approvals of these two drugs in the second line and beyond setting for advanced stage non-small cell lung cancer. We've talked a little bit about the confusion that exists still with what does it mean to be PD-L1 positive. And now I'm going to talk a little bit about some of the adverse events. So those of us who are medical oncologists are used to dealing with a lot of toxicities related to chemotherapy, such as neutropenia, and we don't really see that. Nausea, vomiting, we don't really see that with these drugs, but we do have a host of other toxicities to be aware of. So here's a case. This is a 72-year-old woman with a 30-pack-year smoking history. We've talked about her before. So her biopsy was positive for lung adenocarcinoma. She got the carboplatin pemetrexed, didn't respond, but did well on a PD-1 antibody. She was on a clinical trial. But after 7 months, she had a non-productive cough, and she has these bilateral infiltrates, which you can see here on this picture. So then the question was, how do you manage this patient? So in this case, they held the treatment, and they started her on prednisone. And after 2 months taper of the steroids, the infiltrates were improved, and she continued to have a persistent treatment response. Now, there are many different ways of thinking about how to treat these patients. But one thing that's important to note is that you really should not be afraid of starting steroids. There was concern that by giving steroids with the PD-1 inhibitors, we would be reducing the effectiveness of the drugs. And it's true that we don't want to initiate steroids as we're initiating these drugs. We want to limit any steroid use up front. But in the setting of any toxicity, especially in the setting of pneumonitis, you want to be quick to start your steroids. There was a recent analysis presented at the World Lung Conference, the ISLC WCLC conference that was held in September in Denver. Natasha Lyle was the LEI-GHL. She was the presenting author on that. And what they showed was that for patients who needed to get a steroid because of an adverse event, patients tended to respond very well to those steroids. Many of them were actually able to resume treatment with a PD-1 antibody at the time when those infiltrates or whatever the immune reaction was had improved. And if they looked at efficacy, there was no clear reduction in efficacy for those who needed the steroids. Now, it's small numbers. We can't say anything definitively, but at least helps to reduce some of the fear that is out there about giving steroids for patients who are developing toxicity. in the initial development of these drugs, there were a few patients who died from pneumonitis, and that was because of not really recognizing and not really knowing how to deal with it. In more recent trials, there really haven't been any pneumonitis deaths, and that's because we've learned as a community that if you start seeing anything that looks like it might be pneumonitis, you just stop the drug for a while, put them on steroids. If the patients resolve quickly and are doing better, you can think about a re-challenge, but you've got to start those steroids. I wanted to emphasize that a lot. Okay, so these are some of the toxicities that we see with PD-1 and PD-L1 blockade. So rarely, occasionally you can get this pneumonitis we just talked about, or other grade 3, 4 toxicities, encephalitis. There's any organ, you can talk about it with an itis, and it's possible that you can get that toxicity with one of these drugs. So that's what I talk about with my patients. Anything new or different, we want to know because we need to assess whether it's an autoimmune reaction. Somewhat more common are going to be fatigue, rash, which can be macular, papular, or pruritus, and that can just be usually treated topically. Diarrhea or colitis. If that's happening, you want to start your steroids, but you can taper slowly. Hepatitis, liver enzyme abnormalities, again, steroids, hold drug, potentially can retreat if it improves. Infusion reactions, not that common. Endocrinopathies, particularly hypothyroidism, pretty common. So you want to be very mindful of that and think about checking labs more regularly than you would otherwise, looking at those particular issues like hypothyroidism. But the fatigue is the one that's a bit more common, and that's what we really talk about. And then warning patients to be mindful of these things and reminding clinicians you've got to check your labs. So with these immune events, there's a variability in when they can happen. The average is 6 to 12 weeks, but it can happen quickly. So if someone gets worsening shortness of breath, you want to get your x-ray quickly and look for evidence of pneumonitis. If they're getting diarrhea, don't assume it couldn't be from the drug because it's not been 6 to 12 weeks. You've got to treat appropriately. This can occur, though, within days of the first dose, as I just said. It can happen after several months. It can happen after discontinuation. So there's this average, but there's a huge range. Patient complaints are autoimmune and drug-related until proven otherwise. As I just said, you've got to think of it. If you think of it at all, hold the drug, start the steroids, see if they get better. You do also want to be thinking about infection, metabolic causes, tumor effect, all of those as well. But think about it, evaluate it, and treat. This is a little algorithm for thinking about how to manage it. For any grade 1 adverse event or just hypothyroidism, you want to manage symptoms, do hypothyroidism replacement with thyroid hormone, and then you can continue treatment. If they've got a grade 2 pneumonitis, nephritis, colitis, hepatitis, asymptomatic hypophysitis, anything that's grade 3, hold the drug. Give them the steroids. After improvement to grade 1 or better, you can taper the steroids, and then you can resume if they still have no clear recurrence of those symptoms after they're off steroids. But you need to stop if it doesn't get better within 12 weeks. If you can't taper the steroids, less than 10 milligrams a day of prednisone or the equivalent within 12 weeks. Okay, so how do we manage these adverse events otherwise? This is, again, sort of a continuation of that discussion. If they've got a grade 3, 4 pneumonitis, nephritis, infusion reaction, any other life-threatening grade 4 event, any severe grade 3, then you just stop the drug. Start steroids, stop the PD-1 inhibitor. And then there's some guidelines with the degree of hepatitis to look for as well. Okay, so key to optimal patient management, all members of the healthcare team need to know about these potential toxicities. Rapid and timely diagnostic and therapeutic intervention is imperative for optimal control of the immune-related adverse events. Persistent grade 2 immune-related adverse events or grade 3, 4 immune-related adverse events are treated with steroids. Early discontinuation of steroids may predispose to relapse. Now, I've had several patients who have really pushed back when I've talked about giving steroids and said, oh, that's going to stop the drug from working. And it's really important that we educate patients that if steroids are needed, they're needed, and they're not necessarily going to reduce the efficacy of the drug, but without them, the patient could have very serious complications. So that's an issue that has come up a few times. You do want to think about reinitiation if possible. Approximately 5 to 10% of patients experience evidence of enlarging tumor lesions prior to response. So it's kind of not really an adverse event, but something to be mindful about, and that's the pseudoprogression. Now, the pseudoprogression phenomenon has been, that message has gotten out very well to patients and to providers. And so I want to mention it here, but I want to not overemphasize it. I've had a couple of patients who have had absolutely definitive progression who, again, argued with me that they couldn't possibly come off the drug because they had pseudo-progression, even though their symptoms were much worse. So a pseudo-progression can happen. It's rare. It doesn't happen in the setting of worsening symptoms. It's only something that you will see sometimes radiographically in patients who are otherwise feeling better or stable. So if the patient is symptomatically worse, do not assume it's pseudo-progression. You really need to think about changing therapy. Optimal management is attainable through continued communication between all members of the healthcare team and the patients. So this education is critical for all healthcare members. It's also critical for the patients and their families. Okay, so patient education piece. For the patient education, you want to talk about adverse event profiles that differ from the standard chemo, which we've just gone through. You want to emphasize the early recognition of the immune-related adverse events, and you want to make sure that they tell you about them. You don't want them to walk away and be afraid to mention, I'm getting a little more short of breath, I've got a worse rash, because of fear that if they do, they'll be put on steroids and that will lead to them not having a cancer response. So really important to emphasize that they've got to get treated if they're having a toxicity. That's really the best thing for them. The immune-related adverse events are rare. They're treatable. They respond well to steroids. The patients need to know who they need to call after hours and weekends. Reinforce those teaching points at every point of contact, office, treatment visits, phone contact. Make sure the patients know that they need to let us know, their primary provider, if they are admitted to another hospital. Because again, if you as the treating oncologist know about this drug and have started it for the patient, but they end up at a faraway hospital that doesn't have the education about it, they might not get treated appropriately, and if you don't know about it right away, it might lead to a bad outcome. Okay, patient and family education, same as we talked about. Make sure the patient and their caregivers know about these drugs, know about the potential toxicities. Make sure they know about how frequently they're coming in. The pembrolizumab is every 3 weeks. Nivolumab is every 2 weeks. The patients need to know that they might not immediately feel better. It might take some while before they have a response. They need to know that the toxicity, they might not feel it all for a while, but could come up later. And we also, it's important that they hear about this potential for pseudoprogression, but not to overemphasize it. Okay, so we've talked a lot about where we are today with treatment options. We have talked about the adverse events to be mindful of and how best to manage them. And now we're going to talk about the future directions for immunotherapy in non-small cell lung cancer. So this is one of the newer drugs, atezolizumab, formerly known as MPDL3280A. I'm not sure which one of those is easier to say, but atezolizumab is the name for now, compared to docetaxel in previously treated non-small cell lung cancer. So this was a randomized, large phase 2 study, and patients in this trial either got atezolizumab, and this is a set dose, 1,200 milligrams IV every 3 weeks, so it's another every 3-week drug, like the pembrolizumab's every 3 weeks, compared to standard docetaxel at every 3-week dosing as well. And they were looking at overall survival in all patients, but also based on PD-L1 expression. And as we'll get into, their PD-L1 assay is different than what we have with nivolumab and different than what we have with pembrolizumab. So in this particular assay, they're looking not just at the tumor cell expression, that's the TC here, but they're also looking at the immune cell, T cells, so that's the IC. And so for the patients that had no expression of PD-L1 on either the tumor or the immune cells, the overall survival was the same on atezolizumab versus docetaxel, 9.7 months, what we have seen before with docetaxel as a single agent. However, as we get into expression of the PD-L1 on either the tumors or immune cells, a different story emerges. So if we look at the tumor cell expression 2 or 3 or immune cell 2 or 3, that's 100 of the patients on the trial, for the atezolizumab arm, the overall survival was 13 months versus 7.4 for the docetaxel. And when we look at the highest levels of expression, the overall survival hasn't even been reached for atezolizumab. It's 11 months for docetaxel, hazard ratio of 0.46, not quite statistically significant because of small numbers probably. And when we look at those, grouping all of the 1, 2, or 3 expressions, tumor or immune cells, that's going to be the majority, like 2/3 of the patients on the trial. We still haven't reached that overall survival mark at the time of presentation. It was 9 months for docetaxel, so about what you've seen for those without any expression. Hazard ratio is 0.63. It is statistically significant. So for progression-free and overall response, there's similar trends in outcomes for atezolizumab versus docetaxel based on the PD-L1 expression. So in all patients, there wasn't a big difference between those patients getting atezolizumab versus docetaxel. In the patients with the highest level of expression, the level 3s, there was a hazard ratio of 0.57 favoring progression-free survival for atezolizumab. The overall response in all comers was the same at 15%, but in the highest levels, at the level 3s, response rate was nearly 40% versus only 13% with docetaxel. So this is interim analysis, more data to come, but really in this particular drug emphasizing the PD-L1 expression. And this is a different way of looking at that information, activity of the atezolizumab by immune cell or tumor PD-L1 expression, basically with higher levels of expression, higher responses. Okay, so this is the immune cell infiltrate staining, tumor cell staining, and this is looking at the percentage with the different levels of expression and whether they had a good response or just stable disease. So the orange are those having at least a partial response. And you can see that if there was high expression, a large number of patients, if there was high expression on the immune cells, I should emphasize, then there was a very high likelihood of response. And if there was a high expression on the patients who had the tumor cell infiltrates, this is a tumor staining positivity, then you could have stable or responding. So in this particular assay, it's the immune cell expression that seems even more potent. Again, a very different response than what we're seeing with the PD-L1 assays with the other tumor types. So we've got a lot of analysis still to do in trying to understand what it means to be PD-L1 positive. Okay. So this is another way, again, of looking at that same data. This is not from this trial. This is from a different study looking at atezolizumab. So in this analysis, you can see here it's relatively small numbers. You can see that the response rates for patients with the highest levels were quite high. It was 83%. However, there's only 5 patients. And if you look at those patients that had low levels or no expression, there were still some responses, but again, pretty small numbers. So again, showing us that there's something to this PD-L1 expression, perhaps more for immune cell levels than for tumor cell levels for the atezolizumab assay, but different than what we're seeing with nivolumab or pembrolizumab. Okay, this is another trial of atezolizumab versus docetaxel. This is the OAK trial. This is again in previously treated patients. It's a much larger trial. This is a phase 3, so we don't have those results yet. And these are some data with some of the other compounds. So this is the durvalumab or the MEDI4736 by itself. The response rate was again around 20%, maybe a little higher in the squames. Adverse events, not that different than what we're seeing with the other drugs. When we look at this combination with durvalumab plus an anti-CTLA-4 antibody, which is tremelimumab, you're seeing a slightly higher response rates, closer to 30%. Somewhat higher toxicities as well. There's been data looking at pembrolizumab plus ipilimumab with a response rate around 40%, somewhat higher toxicity than what we see with the drug alone. There's also data with ipilimumab plus nivolumab, and most recent data was looking at giving the ipilimumab on a fairly infrequent schedule, like every 12 weeks. With the continuation of the nivolumab on the 2-week schedule. And those response rates were also over 40%. So there's probably something to that combination. It's just figuring out how to give it with less toxicity. So this is some more data on the durvalumab plus or minus tremelimumab versus standard of care trial. So this is an ongoing phase 3 trial, and there are actually a couple of them looking at durvalumab versus the combination versus standard of care chemotherapy. This is a schema kind of looking at the immune response in a different way. Again, we, at the very beginning of this lecture, went through what's happening when we're getting an immune response. This slide is really emphasizing as we go through those phases of an immune reaction, what are some of the areas we can think about targeting. So with number 1, this is the release of the antigens. So there's work looking at how do we kill a cancer cell, which is going to release more antigen, which is then going to lead to a better immune response? So the combination's looking at chemotherapy. In first line, there's some very intriguing data looking at atezolizumab as well as some of the PD-1 drugs, plus first-line chemo with response rates in the 60% range. So we'll see if that pans out. There's a lot of interest in looking at these drugs in combination with radiation. Again, it's a great way to get some tumor antigens released, get a better immune response, and also with targeted therapy. We can work here, number 2, looking at cancer antigen presentation. So these are all ways of increasing that antigen presentation. With number 3, the priming and activation. So that's where the CTLA4 comes in, which we've talked about. Also agonists for the CD137, OX40, CD27. Remember at the very beginning of the talk, we talked about some of those sort of pro-immune proteins. So that's where these are coming into play. Trafficking of T cells to tumors. We haven't quite figured out how to do that better, but that happens pretty well. 5 is infiltration of the T cells into tumors. So maybe anti-VEGF agents are going to improve the delivery of these agents into tumors. So that's being looked at. Recognition of cancer cells by T cells. So that's where the CAR and CAR T cells come into play. And then the killing of the cancer cells, that's the anti-PD-1, the anti-PD-L1, and the IDO inhibitors, where they're taking the brakes off the immune system, getting better cancer cell kill. So in conclusion, immunotherapy for lung cancer can induce durable responses and can result in prolonged overall survival. Different patterns of response with checkpoint inhibition require ongoing education for the patients as well as for the entire care team. This has to do with that pseudoprogression, which again can happen, but it's rare. So it's fine to mention it, especially before you go into interpretation of your first scan with the patient. But don't be misled. If the patient's symptomatically worse, it is a true progression, and that's far more likely than the pseudoprogression. Pseudoprogression is rare, at most 5%. Real progression is going to be somewhere around 80% still, with these drugs only working in about 20% of patients. So don't be misled by that. Fine to know about it and think about it. We certainly don't want to take patients off too soon, but at the same time, you don't want to miss a true progression. Immune-related adverse events are a unique spectrum of adverse events with checkpoint inhibition that require learning new ways to manage toxicity. Again, make sure the whole team knows this, make sure the patient and their caregivers know this so that they can be on the lookout. Not everyone gets these toxicities. Many patients feel great on these drugs. Some just have fatigue. Some people never have these. But if the patient is having a true immune-related adverse event and it's not caught early, withholding the drug and starting steroids, you could really end up in a significant problem for the patient. Improved understanding of the immune system and ongoing clinical trials with immunotherapy will likely result in an ongoing evolution in treatment for patients with non-small cell lung cancer. I have just brushed the surface today with ongoing trials. If you can think of a targeted drug, I can guarantee you it's being combined with a checkpoint inhibitor, PD-1 or PD-L1 drug, and usually with multiple different combinations. There's chemotherapy trials, radiation trials, IDO trials, many studies ongoing, and it's going to be a very exciting time in our treatment for our lung cancer patients. And now we get to do questions and answers. So hopefully there'll be some coming in from the audience.
And at this time, we would like to take any questions you might have for us today. If you haven't already, to ask a question over the phone, press star and the number 1 on your telephone keypad. To ask a question via the web, click on the Q&A button on the lower left-hand corner of your screen. Type in your question in the open area and click Send to submit.
Okay. So I just got a question about how do you decide between using nivolumab and pembrolizumab in your patients? So that is a great question and not a very easy one to answer, actually. So of course the drugs have some differences. If you look at the response rates overall, hard to tease apart those differences. If you look at the safety profiles, hard to tease apart those differences. There are differences in frequency of administration. So the nivolumab is an every 2-week drug. Pembrolizumab is an every 3-week drug. So that can matter for patients coming from a distance. Nivolumab at this time does not have a companion diagnostic. So you don't have to do PD-L1 testing before using the drug. And with squamous histology patients, it didn't seem to matter, and so that's fine. With the patients with non-squamous, there was a difference to some degree by level of expression. So if you've got a patient and you really want to know up front whether they're likely to benefit or not, then you're going to be thinking about doing PD-L1 testing. If you're going to be thinking about doing PD-L1 testing anyway, then pembrolizumab has a companion diagnostic, a little bit different than the test for the nivolumab, but in both cases can help you get a better sense of likelihood of response. We don't know about insurance reimbursements. That's going to be part of it as well. So it's a lot of back and forth, and I think it's probably good to have experience with both of them for your patients as well. So I don't have a great answer to that question right now, but two good choices for our patients. Okay. Oh, and then there was a question that maybe you'll be able to better answer, John, about being able to see the slides for kind of a review over time, because a lot of that immunotherapy goes by pretty quick. And I guess, go ahead.
Oh, I'm sorry. And the slides are available at clinicaloptions.com.
Great. So clinicaloptions.com. And then another question about how do we express PD-L1 expression in all patients? Do you use the same assay for the pembrolizumab versus the nivolumab? Again, another great question. And the answer to that is no. Even though they're both looking at PD-L1, there are different ways of looking at it. And the differences have to do with which antibody is being used to identify the PD-L1. And so those are there are commercial companies where you can send for analysis, and I think a lot of the pathology departments at various institutions are also starting to develop these assays. So right now it's different assays as the companion or complementary diagnostic, and right now it's pretty much all going to be send out tests to different companies, but these are all very, very recently approved. October 2nd and October 9th were the two dates there, and so we're still kind of working all that out. Okay. Let's see. So another question that I'm asked a lot about is the steroid question, and I already went into that some in my talk, but I just want to bring that up again because I was just the hospital attending doctor a couple of weeks ago, and we did have a couple of patients come in with immune-related adverse events. And in one in particular case, the patient and her husband were absolutely adamant about not getting steroids. And I had to go through a lot of education with them and with the treating physicians who hadn't used a lot of these drugs before about the importance of steroids whenever there's a question about an immune-related adverse event. And if it turns out after further analysis they didn't have it, you haven't done any harm by giving a few days of steroids. But if you've missed it, you really can get into trouble. So there are patients where there have been fatalities from pneumonitis. Again, many of those at the very beginning of the development of these drugs. Now that we recognize and treat, it's okay. But I just want to emphasize again that not to be afraid to use steroids. Okay. And then there's another question about adverse events and how do you manage them, and are you able to usually resume treatment? So the question, and that's resume treatment after steroids. So we went through that a little bit. So the most common is going to be fatigue. That one doesn't really respond to steroids, and that's a little bit harder. Fatigue management in general is going to be making sure patients are getting enough rest, making sure that they're getting some exercise, eating well, sort of the usual things that we grapple with our cancer patients. Rash can often be managed just with a topical steroid. Hypothyroidism can be managed just by thyroid replacement therapy. But if you've got a transaminitis hepatitis, if you've got colitis with diarrhea, if you've got pneumonitis, shortness of breath, those patients are going to need to have drug held briefly until resolution, and they need to start on steroids, fairly high dose prednisone with then a gradual taper. That taper needs to go over at least a month if someone's really had a grade 2 or especially a grade 3 adverse event. If they respond well to that steroid and symptoms get better, and they're able to stay with good management off of steroids after that gradual taper, then yes, you can re-challenge, and there have been many patients who have been successfully re-challenged. But it takes time, and this also has to be in a setting where the tumor is still controlled. If as you stop the drug and the patient's having that adverse event, if they're also having significant progression of their tumor, obviously you're going to need to move on to something different and stop. Trying to answer the specific question, those are the typical adverse events. That's the way we think about managing them. And then the resumption is, again, if you can taper them off steroids, the symptoms don't recur, it is okay to re-challenge, and that has been done successfully with all of the PD-1 drugs available to date, and it's also been looked at with the PD-L1 drugs that are in trial still. Okay. We'll give people another few seconds to think about any other questions they might be thinking of.
And Nita, can you check to see if we have any questions on the phone line, please?
There are no audio questions at this time.
Okay. Well, it's looking like we're just a couple minutes short of the hour. And let's see, I think I'll just do a quick mention that I've talked about how challenging it is with the PD-L1 assays and the fact there are multiple other assays. There are also other things that we're looking at to see if we can select which patients are most likely to benefit from these drugs without excluding patients who might benefit. And so this idea of mutational burden is something that's come up. There are these ideas that patients who have a heavy smoking history might be more likely to respond, perhaps because they're going to have more antigens to choose from in the tumor. They're going to have more mutations that have developed. And so there are assays being developed trying to look at that as well. So it's probably not just going to be a simple PD-L1 assay that we're doing in the future. It's going to be much more complex. But at this point, the PD-L1 is the closest that we've gotten to having a good selection. All right. Well, I think we're hitting the 5 o'clock hour now. It's been great doing this. And I don't know, John, if you have any closing words you wanted to give.
Excellent. Thanks again to our participants for joining us today.